Okay, for the next 30 minutes we're going to review the anatomy and diseases of the suprahyoid neck. That's the core soft tissues, obviously, from the skull base to the hyoid bone. It can be differentiated, and if we describe an infrahyoid neck below as anything below the hyoid bone, many of those spaces go to the infrahyoid neck, but we'll emphasize the diseases above. In that time, we'll talk about the anatomy and current terminology. We'll talk a little bit about cranial nerves again and patterns of mass development and recognition, and finally some space-specific differentials. I'm going to show you two kind of approaches that I find myself using now for many years. When I started in head neck radiology, everything was everything. Peripharyngeal space was basically everything in the suprahyoid neck, and so nothing was broken apart. And you couldn't actually, your differentials were a mile long and not very useful, and your anatomic discussion wasn't helpful for the surgeons. So by taking this area and breaking it into smaller units that have different things in them, we can then begin, when we see disease in these spaces, to talk about a much smaller group of differential possibilities. We can also take the lesions that leave the surface of the pharynx. So if I'm a big tumor and I leave the pharyngeal-mucosal surface, where am I going? Back then, there really wasn't, you'd say, you know, it's invaded the deep tissues. Now we talk about the spaces and the structures that have been invaded. So here's an example where we have an obvious enhancing mass on an axial MR at the level nasopharynx, and then here is that same lesion on a T1 pre. And so I can tell I see styloid as being displaced, that this is, these are in plenty of spaces that you can pick from: peripharyngeal, pharyngeal mucosal, masticator, carotid, retropharyngeal, and prevertebral or perivertebral. And in this case, out of that, I'll pick carotid because of its invasion. It's displacing the peripharyngeal fat anteriorly. It's lifting the styloid process. And as I look at this now, I also see a tremendous amount of vascular high-velocity flow voids. So what is my differential of this space? Well, the carotid doesn't have much in it, so it has glomus bodies, nerves. So when I think about lesions of this area, I think of the paraganglioma lesions, schwannoma, neurofibroma. A diagnosis, I would say, glomus vagali, because it's 2 centimeters below the skull base in its center. It's not up in the jugular foramen. It's not down in the carotid bifurcation. It also has all of these high-velocity flow voids. So location and imaging features and space, I have a limited differential, and I conclude something that's useful. So that's a space-specific analysis. Second way to look at things is when it's in multiple areas, as in sometimes in infections or big invasive tumors or congenital lesions that form before the fascia form. So in this case, I've got a patient who is trismus and an abscess, maybe, and we're imaging them. They can't open their mouths, and we start looking at these scans. The 2 images just to concentrate on. What space is it in? Again, same list. Well, it's in multiple spaces. I can see involvement in the peripharyngeal space, and that's that's fluid, so that's frank abscess now. And I can also see involvement of the masticator space, and there is some pus also inside that fascia there. So that's abscess and phlegmon. And then finally, the parotid and superficial spaces have cellulitic changes. And so my report then describes abscess in the peripharyngeal and masticator spaces, with cellulitis in the surrounding superficial spaces and parotid spaces. And we know this is then a transspatial or multiple contiguous space abscess. And in this case, I'm just showing you an example of transspatial disease description, again, used in the setting of big congenital lesions, lymphatic malformations, etc., infection, and malignancy. So I found this approach to reading lesions of the suprahyoid neck, infrahyoid neck, oral cavity, and other places very useful. In this case, we are looking at the suprahyoid neck. When I started, it was a small group of us that were working on this kind of these definitions and these fascia All the fascia obviously came from the anatomic dissections from the 1800s, and more recently the spaces were named variably by the surgeons as they drained abscesses out of them because they were fascial contained spaces. And then we put together sort of a pragmatic distillation of that into a mixture of simple terms and spaces for the spaces. So in yellow I have the superficial layer of deep cervical fascia. In purple I have the middle layer, and in, let's say, blue I have the deep layer. And so we see the masticator and parotid spaces circumscribed by the superficial layer. We see the pharyngeomucosal surface or space on its deep margin, the middle layer, and we see the deep layer of cervical fascia going around and defining the perivertebral space and the lateral margins of the retropharyngeal space. Notice all three layers of deep cervical fascia contribute to the carotid space. So this can be a very tenacious fascia in the lower neck and quite thin and hard to define in the nasopharynx. Again, down at the level of oral cavity, I see masticator and parotid with the superficial layer. I see the deep surface of the pharyngeomucosal surface defined by the middle layer, and I see the deep layer defining perivertebral space, danger space, retropharyngeal space on its lateral margin, and all three layers in the carotid space. Today we're going to talk about 5 spaces, not all of them because, again, we have time limitations, and that's fine. We're going to talk about the principal 5 big spaces of the suprahyoid neck, the parapharyngeal, the pharyngeomucosal, masticator, and carotid spaces. So parapharyngeal, pharyngeomucosal, masticator, parotid, and carotid. We'll do it one space at a time initially, and then we'll break into diseases of the spaces. Parapharyngeal space is this deep space that's got complex fascial margins, but is 2 tubes of fat that run in the off midline deep suprahyoid neck. The use of the parapharyngeal space is because we can always see it. Whether it be CT or MR, it's very high signal on T1 MR. It's very low density on CT. And so we can always find it, especially when we have bigger lesions. It helps us define where lesions are coming from in the surrounding spaces. The parapharyngeal space, as we said before, empties into the posterior submandibular space. So either tumor or abscess that gets there can display themselves as an angle of mandible mass, and really then would just be the tip of the iceberg of a much bigger lesion. When we think about the suprahyoid neck spaces, you want to think about how they interact with the skull base and what cranial nerves they interact with, because again, that will define the perineural tumor. It will also define where tumors in them get through the skull base into the intracranial compartment. In the case of the parapharyngeal space, we have a very bland area of involvement. There's no vessels, no nerves, a little bit of bone. So nothing's going on in the cephalad end of the parapharyngeal space. So that was the parapharyngeal space. Now we're going to move to the pharyngeomucosal surface, also known as the pharynx. And as I said earlier, that pharynx was defined for us by the surgeons years ago because most of the tumors come from there. But as you move off the surface of the pharynx, you need to have a descriptive set of spaces, spatial terminology that you can use to tell in your report, to tell the surgeon or the radiotherapist or whoever where this lesion went to. Where did it go to? So let's look at the pharyngeomucosal surface or space, remembering we have mucosa, we have a lymphatic ring, the adenoids, the palatine tonsil, and the lingual tonsil. We have minor salivary glands, and the constrictors, and the pharyngobascular fascia, It extends from the skull base to the hyoid bone. It has a naso-oropharyngeal and a hypopharyngeal component, and as you would not be surprised based on these contents that we have squames and lymphoma and minor salivary gland malignancy in this area. Notice the nasopharyngeal, oropharyngeal, and hypopharyngeal mucosal surface or space. In terms of its interaction, well, for those of you that were in my morning session, we talked about the foramen lacerum. Well, here's the middle layer of deep cervical fascia as it attaches to the skull base, and inside that fascia is the foramen lacerum. And bilaterally, and so a roof of nasopharynx tumor that goes up against the clivus and the base sphenoid can access the intracranial compartment through these little cartilaginous covered areas, the foramen lacerum. The middle layer of deep cervical fascia also, as it extends cephalad, becomes the pharyngobasilar fascia, or they're very closely approximated. There's a gap in the top of the pharyngobasilar fascia called the sinus of Merigagni, and through that comes the distal eustachian tube, which you see coming and being opening here with its torus tubarius cover. It's the cartilaginous eustachian tube end, and we have the levator palatini muscle on the inside of the fascia. So it's possible for a tumor to escape posterolaterally through the sinus of Merigagni to the other deep tissues and go out in that direction. A generic mass of the pharyngeal-mucosal space enlarges the pharyngeal-mucosal surface. It often spills into the airway because there's nothing resisting it in that location. So they're often pedunculated, but as it enlarges, it also pushes on the parapharyngeal fat from medial to lateral. So medial to lateral. And as a result, that displacement pattern of the fat of the parapharyngeal space helps us define lesions of the pharyngeal mucosal space. So lesions in this location, we're not going to cover them all. Some of the starred ones we'll talk about, but we're talking about congenital lesions, mucosal lesions, tonsillar lesions, minor salivary gland lesions. And if you go down this list, we won't read them all to you because they're in your syllabus, I believe, but the squames are very important, so we'll talk about those, lymphoma and minor salivary gland. So we're going to pick out the lesions that are the malignant lesions of this area. So squamous cell carcinoma of the nasopharynx and oropharynx can occur here. Here we have an MR that shows a pedunculated mass that's filling the back of the nose and filling the airway and beginning to violate the fascial boundary at this point. We also see retropharyngeal nodes on either side. This one's big enough to be very worried about. The presence of nodes would certainly be very suspicious for spread into that area. And we think about squames, we think about non-Hodgkin's lymphoma and minor salivary gland malignancy. We happen to have a PET CT on this one, and we see both nodes are quite metabolically active, and so they are considered malignant for the purposes of staging this tumor. Now, non-Hodgkin's lymphoma also occurs in this location because we have Waldeyer's ring, 3 tonsils within the pharyngeal mucosal space and along its surface. So in this case, we see 2 very large palatine tonsils and some kind of nodularity along the wall of the lingual tonsil and lateral wall of the oral pharynx. Here's the PET CT on this case, and we have 2 very metabolically active areas. These were both foci of non-Hodgkin's lymphoma and nodes that were also positive. Finally, minor salivary gland malignancy can live in this location. This is by far the least common of the malignancies of the pharyngeal mucosal surface. In fact, it's very rare to see them other than at this hard-soft palate junction. I show you one that it would be exceedingly rare, which is a tonsillar, lingual and palatine tonsillar minor salivary gland malignancy. They often have bizarre enhancement patterns, and on MR they often have very bizarre signal characteristics from fibrous tissue and other glandular elements that get involved as they grow. There we see this lesion on the coronal image where the tonsil is quite large and it's extending out onto the soft palate. The masticator space is two very large lateral spaces in the suprahyoid neck. The superficial layer of deep cervical fascia splits around both. Although it's not seen, the fascia is not seen, it's a relative barrier to the spread of tumor. Within this space, we have many things. We have the mandible itself, the body, ramus, and condyle. The TMJ is a denizen of the masticator space. The four major muscles of mastication are there. We have the cranial nerve V3, again, perineural tumor to think about, and the pterygoid venous plexus is here, which can cause a pseudolesion. And so we see the lateral pterygoid, medial pterygoid, temporalis, and masseter muscles, and the mandible, the pterygoid venous plexus here, and V3, I think can be, I'm having a little trouble seeing it there, I think it's right here inside the fascia. The muscles of mastication are all innervated by that masticator nerve that comes off quite early, and if you cut the V3 at the skull base, you will lose all the muscles of mastication on that side, as you will lose the mylohyoid muscle and the anterior digastric, which is the distal mylohyoid motor branch off that. So keep going here. Let's move along. If I see an invasive lesion of the masticator space, if it didn't come from a mucosal surface, first you want to think about sarcoma, and we'll talk about that in a moment, but the other thing you're going to want to do is go find what? The foraminal valley. It's the first thing I want to go find. I want to look at Meckel's cave in that area, and in fact I want to see the lateral, sort of the area where the fifth nerve goes in the lateral pons, because perineural tumor is alive and well in this area. Terms we talked about, I'm losing my track of what I've talked about, but some other, maybe with the registrars, is the fact that the masticator space has a masticator space proper, sort of infrazygomatic masticator space, and a suprazygomatic masticator space. The superficial layer comes along the lateral zygoma, zygomatic arch, and down under the mandible and up medial to ovale here. So it's a very large space, and its cranial-caudal dimension is much greater than we tend to think about. So bear that in mind, because in the olden days, we used to have radiation therapy boost mostly to the area of the tumor without sort of understanding this area, and I'm talking 25, 30 years ago, and people would recur up in the suprazygomatic masticator space because it was already in the muscle. In terms of masticator space abutment, it's a very broad abutment of the undersurface of the zygomatic arch. Remember, there's no fascia under the zygomatic arch, so it can go through and through from the infrazygomatic to the suprazygomatic masticator space. The foraminal valley and the foramen spinosum are both within the confines of the superficial layer of deep cervical fascia. The TMJ is in this area as well, and so we have all kinds of lesions that can occur here. If you have a masticator space tumor or mass, it enlarges. It usually injures the mandible in some way and then begins to push on the parapharyngeal space from anterior to posterior. In very large lesions, this can be helpful. So I have a very extensive masticator space differential. Notice the contents, V3, mandible, muscles of mastication, and mandible teeth, an abscess, squames that can invade there, non-Hodgkin's lymphoma, perineural tumor along V3. I showed you one of those when we were in the oral cavity. Masticator muscle hypertrophy, cranial nerve V3 denervation, sarcoma, and malignant nerve sheath tumor, which may also be a sarcoma. So if I see an invasive tumor in the masticator space, this is a child who was treated multiple times for their masticator space abscess until the concept of sarcoma was mentioned. This was a fibrosarcoma. Masticator space is the home of primary sarcoma of the deep face. And so chondro, osteo, rhabdo, fibro, synovial, and Ewing's, I've seen them all, and they mostly like to begin here. Here's a chondrosarcoma with its funny little chondroid matrix. And a rhabdomyosarcoma, again. Notice how big this lesion has become with the destruction of some of the inner table of the mandible, but we still see the parapharyngeal fat being pushed by this tumor. And there it's enhancing. Non-sarcomatous tumors, malignant nerve sheath, non-Hodgkin's lymphoma, and squamous cell carcinoma, usually they come along the third division of 5. Here's another example of The same kind of thing I showed you in the oral cavity area. We have an alveolar ridge primary squamous cell carcinoma that was resected and radiated, and then the patient came back with their progressive numbness, and here is ovale, which is quite large, and this tumor has come up V3 and is entering the intracranial compartment. So you hear head and neck specialists talk about perineal tumor a lot because we've all been burned by them. We just didn't see something, we forgot to look or whatever, and it's those mistakes that stay with us forever. And here this one is puddling actually in the floor dura of the middle cranial fossa. Parotid space, we have the superficial layer of deep cerebral fascia. We have the contents of the gland, facial nerve, the extracranial facial nerve, parotid nodes. Although it is not a numbered nodal station, there are 20 or so lymph follicles in each of the parotid glands. Retromandibular vein and extracarotid artery are all in the parotid space. So we see all those contents. We'll keep going. Again, we look to the facial nerve in the parotid space as the conduit for perineural tumor. Fortunately, it doesn't go directly into cranial. It has to go all the way through the temporal bone. So often, even if we miss it, we catch it later as it's headed up through the stylomastoid foramen and up the mastoid segment of the facial nerve. We've all seen them go all the way into the CP angle, especially the kind of the low-grade ones where they're not symptomatic until very late. Couple of things to think of. The parotid gland is a nodal station. So if you've got tumor of the scalp or the external auditory canal, its first order drainage is into the parotid. If you do only bone window, temporal bone CT, you will miss that. And so you should always use at least one soft tissue sequence you should have one soft tissue collection in every temporal bone CT that you do to look at the parotid, because it's generally fatty in adults and you will see the nodes that are sitting there. Also, biopsy of the parotid gland is not, you can needle, that's fine, but there is no such thing as resectional biopsy of a parotid mass. And this does happen because, unfortunately, the tumors may occur on the tail, way down below, and when that happens, a general surgeon may think of it as a neck mass and take it out and takes the marginal mandibular nerve with them. At least in the United States, approximately a $1 to $2 million mistake. So you do not need to know about that. Parotid space abuts the external auditory canal. We see mastoid tip, external auditory canal, and the stylomastoid foramen we see medially and deep. A lesion that is very large in the deep lobe of the parotid will still, if it's benign, you can still see the parapharyngeal space being pushed medially, the stylomandibular notch enlarges, and by and large, if you see that pattern, that's a benign mixed tumor until proven otherwise, because nothing else can grow that large in that deep strategic area and not cause huge amount of symptoms. Just to remind you that look how far down the parotid extends. I think I've got one more picture. Let's go back one. So the parotid tissue extends all the way just above the hyoid bone. This can appear to the clinician to be in the neck and not in the parotid. And so when you see this, a lesion that's deep to the platysma and anterior lateral to the sternomastoid muscle, it's not over where the jugular-gastric node is, it's where the parotid tail lives. And that is an earring lesion until proven otherwise, and therefore a parotid lesion. And you need to be very well aware of that funny little triangle of fat, which we see here. Again, we will only mention a few of these lesions. Benign mixed tumor, 80% of all parotid lesions. We have Warthin's tumor, and then salivary gland carcinoma. We'll look at those. Benign mixed tumor, again, here's a nice big pear-shaped one. This one had a tonsillectomy before they finally figured out that it was something deep. Can be very much obvious inside the parotid in this case. Benign mixed tumor, well circumscribed. You get very used to that lesion. Multiple lesions in the parotid tails. Think Warthin's. It's the only benign tumor I know of in the head and neck that is stimulated by smoking. Kind of an interesting lesion. I'm going to skip that one and keep going. Then if you've got a parotid mass that has hairy edges, maybe facial nerve paralysis. Beware, you're talking about mucoepidermoid, adenoid cystic, and some of these are actinic cell carcinomas, squames, etc. Adenocystic carcinoma is the tumor in the head and neck where all the perineural tumor began. And so here we have one that was in the parotid. It's invaded into the mandible. It's on V3 here, and we're all the way up in, and we see that same lesion now coming out the internal auditory canal, having followed the facial nerve all that way. And then finally, the carotid space. As we said, all three layers of deep cervical fascia are found around this space. It's a very tenuous fascia up near the nasopharynx. It gets very tenacious as you get down in the area of squamous cell nodes. Isn't that interesting? And then we have the internal carotid, internal jugular vein, 9 through 12, cranial nerves in the nasopharyngeal aspect. The internal jugular nodes are associated with the carotid space, but they're not in the carotid space. They're on the surface. But they very quickly involve, especially cranial nerve 10 and the carotid in the infrared neck, and so it's important to remember their close proximity. As we look at the nasopharynx, we see 4 cranial nerves, 9 through 12, internal carotid and jugular vein, all 3 layers of deep cervical fascia in my tricolored fascial drawing. Remember that this space does extend all the way to the aortic arch, and that as you pass the hyoid bone, you have only one cranial nerve, that being the vagus nerve. At the skull base, there's a lot going on relative to the carotid space. Notice the carotid canal, and the vertical segment of the petrous ICA is seen there, and the internal jugular vein as it comes out of the jugular foramen, and the hypoglossal canal as it drops 12. So we know we get 9, 10, and 11 from the jugular foramen. We get 12 from the hypoglossal canal, and we've got a carotid in there as well. So there's a lot of very important things in the carotid space to remember and be concerned about. The lesions of the carotid space in the suprahyoid neck tend to enlarge and push the parapharyngeal fat anteriorly. It usually pushes the internal carotid anteriorly or anterior medially as well. And here we have a paraganglioma that is enlarging. In terms of actual tumors of the parotid space, they really are mostly 3 types: paraganglioma, schwannoma, and neurofibroma. So we'll show you a couple of those. Paraganglioma is named based on the glomus body group that grows the tumor. So on the cochlear promontory, we have glomus tympanicum paraganglioma. Along the jugular foramen margin, glomus jugulare. 2 centimeters below the skull base, vagale in the nodos ganglion of the vagus nerve. And then carotid body tumor or carotid body paraganglioma in splaying the carotid bifurcation. And I think we sort of can see all 3. So we have tympanicum, jugulare, vagale, and carotid body here. Classic, these are the ones that we've all seen. They're a very common tumor, especially if you happen to have a family or 2 in your community that grows these things, because there's a familial aspect that they grow them madly and in many places. Again, it splays the external and internal carotid arteries. It has high velocity flow voids and AV shunting, so there's a lot of angiographic activity and all of this black stuff that we see, which is all this high velocity stuff. Here's a lesion. Here's the next lesion up, which is the glomus vagale paraganglioma, where we see it below the skull base. Again, we see carotid there and vein here laterally. And there is this lesion sitting just below the skull base. Vagal schwannoma, this is usually a tubular or oval or fusiform lesion. It often has intramural cystic change on CT or MR. We can almost see it going up to the nerve that's contributing this thing. Again, we see the carotid and the vein, so this is a carotid space mass, in this case a fairly typical looking schwannoma. And finally, neurofibroma, 2 different cases. This is, for whatever reason, in the enhanced scan, we see the carotid and the vein in this ovoid thing, posterior belly digastric here. reminds me that that muscle divides the parotid from the carotid space. And this other one, notice the low density. That seems to be typical on the CT. It may be umbilicated or not on the MR. These are isolated neurofibromas, not those in NF1. So to kind of take it home, why this works as a technique is because there are different tissues normally in each of these spaces. What's on the pharyngeal surface is very different from what's in the masticator space. Got mucosa, salivary glands versus muscles and bones, and is different from parotid tissue and nodes in the parotid gland. Is different from the carotid space, which is cranial nerves, glomus bodies, and arteries and veins. And so if you can get it into a space, either by looking at the far end of it or just being able to understand how it's pushing things, then you sit there and you've got it named. You're way down the road to narrowing a diagnosis down to a few very important possibilities. And it can be, at times, as I've shown you, there are certain imaging findings that make it so that you can not only then go with that small list and give it a name. And one of the most fun things about head and neck radiology is if you've actually had a significant empiric experience and have seen these things before, is how many times you can give a lesion a name. And it transforms the treatment path when you do, and it's great fun. So I recommend this technique to you. I wanted to thank the committee, whoever they all were, that invited me, because it's every time I come to New Zealand, it's a complete blast. And the last thing I want to say is that I have no seconds. There's a place called Paderi Crissi. Who's been there? It's Italian. I've got one guy over here. Italian vineyard on this wonderful island, Waiheke, and it has a rosé that is copper colored that I recommend all of you. Thank you.
Well, I'd like to say thanks to all our speakers today. Rick's had to work hard for this conference, 5 talks to register our teaching. He's certainly sang for his supper. We are out of time, but if anybody wants to stay and ask any questions, or if there are any burning questions in the audience now, we'll take a couple. Otherwise, I'd like you to put your hands together again.